Hi, everyone. Welcome and thank you for joining us today. We're thrilled to have you listen in and join us in this panel presentation, The Quest for Quality. My name is Shannon Biello. I am the Director of National Treatment Quality Initiatives at Shatterproof, and I'll be leading today's conversation on quality addiction treatment. So first, I want to tell you what we'll be focusing on. We have a few important key themes. We'll be looking at addiction treatment quality in a number of ways, thinking about how do we find it, how do we provide high quality addiction treatment, how do we measure it, and then how do we think about expanding it so that more people have access to high quality care. Leading us in the conversation today is a diverse group of excellent panelists who understand the opportunities and challenges of quality treatment through their own work in this space. And I want to introduce them now for you. We'll start with Dr. Cesar DeLeo, Vice President and Executive Medical Director of Strategic Initiatives at Highmark. Also with us is Scott Olson, President and CEO of Pathway Healthcare. And finally, we have Andy Thomas, Vice President of National Provider Relations at axialHealthcare. So with that, those are our three panelists. We're really looking forward to our discussion today. And we'll be answering audience questions at the end of the panel. So feel free to type the questions for us in the Q&A box throughout the conversation so that we can address them towards the end of this panel presentation. And with that, we'll get started. So we'll first start with the notion of how do people find high quality addiction treatment? And this is something that we've really thought about in our work at Shatterproof on addiction treatment quality. What we know is that when people first think about and begin their search for addiction treatment, it's hard to know where to go and what to look for. You know, we often have people who resort to the ways in which we find other things. They go to Google, they try word of mouth, they think about the normal information transfer strategies that we use for other practices and goods. So what we find is that the information on addiction treatment and addiction treatment quality is hard to come by, which led us to do our work at Shatterproof, developing a quality measurement system for addiction treatment facilities, Atlas, our treatmentatlas.org platform. But I wanted to start this conversation with the panelists, and Scott, we'll start with you on your perspectives on why finding addiction treatment quality can be so challenging for those impacted by addiction and their families.
Well, thank you, Shannon. You know, it's just, as you said, I think it's very difficult for people. There's an online frenzy, really, of information, and it's hard, I think, for people to really understand what's the appropriate treatment for them or for their family member. Very confusing when you go out there and you're trying to get educated. So, you know, I think that the lack of really kind of a standard of care in the addiction world also makes it very confusing. So I think people are left with just trying to educate themselves and figure it out. I love what you guys are doing at Shatterproof. I know there's some national databases, but it's still very difficult for people to understand, is that the right treatment for me? Is it evidence-based care? Is it going to help me? And how to understand and navigate that really voluminous world.
Yeah, that's helpful. And Dr. DeLeo, I'd love your perspectives as well from the payer world and how you help members find information as they search for addiction treatment.
I think the biggest problems are shortage, stigma, and Google. We don't have good hubs. We don't have a centralized place to give people navigation. And, you know, I acknowledge that that's the great work that Shatterproof is trying to do with Atlas. But there are so many predatory sites out there and predatory treatment centers. We see the pathways going to Florida and California, and how do we protect those people from that aspect of the industry? At the same time, we need to have standards of care. We need to have standards in nomenclature in terms of credentials and how practices are holistic, and we need to have more practitioners. You know, in particular, practitioners who adhere to evidence-based therapy with medication-assisted treatment. So I think those are some of the biggest challenges, and what we can do as a health plan, we can hands-on We can do good transition in terms of peer counselor support and guidance and navigation. And we can try to navigate through our electronic platforms.
Thank you. And Andy, I'll end with you in this question. I think it's important for your perspective as well as someone who has sought treatment, the challenges you might have faced in that process as well.
Yeah. So first of all, I think I agree with everything that Scott and Cesar said. And yeah, when I think about this question, I really think about it probably from a couple of different perspectives. One of which is my own experience finding treatment. So in 2009, I was actually seeing a psychiatrist in Arlington, Virginia. And that process wasn't going particularly well. And the psychiatrist referred me to treatment, and the residential program that she referred me to happened to have been one that a marketer or an outreach professional had dropped off a brochure, the week before. And so my own treatment journey involves getting on a plane the next day and flying across the country to go to treatment, largely because this was just a contact that this psychiatrist had, and really kind of happened, because it was top of mind for that individual. I also think about this question from the perspective of someone that's been in recovery and taken, I don't know how many phone calls from individuals and families over the last 10 years that are seeking treatment. And while that process has been extremely humbling, and I've always made it a point to give as much time as I can to people, I'm not a clinician. I mean, I can't assess someone. And so I think it's really interesting that I've had that experience of finding treatment in a unique way, and that so many folks have reached out to me to find treatment when I'm not a clinical expert in substance use disorders and can't assess folks. So certainly think this is an area that we need to find a standard intake process around, where we match the right treatment to the individual's circumstances, and we get away from the ways in which folks are finding treatment today.
Yeah, and I think I wanna touch on a point that I'm hearing amongst the panelists as we talk through this. We're looking for things like standards of care. Certainly in our work through Shatterproof, we have the Shatterproof National Principles of Care, an attempt to standardize the ways in which addiction treatment is provided across the country, and give some standards and metrics to looking at the quality of addiction treatment. And I wanted to ask the panel here, why, if we have this information on standards of care, and Dr. DeLeo, you mentioned medications for addiction treatment using, evidence-based behavioral therapies, why is it that these, services are potentially not being used, or addiction treatment isn't being, addiction and substance use disorder isn't being treated in the manner that we know works, and how do we, bring the evidence base for treating addiction treatment to the fore so that we can ensure that these evidence-based practices are used?
Well, change is always difficult, and to change an industry's approach or a profession's approach overnight takes time. You certainly, when in this field, you have so many people who have practiced a certain way for a long time, or they themselves went through a certain type of process. They tend to have a bias toward it. But I think the evidence basis indicates, and there are national guidelines around appropriate use of medication for various substance use disorders. And the way that we get there is that we use measurement bases for quality outcomes and quality processes, and we share that information. And sharing that information is powerful. We do academic detailing, and then change behavior over time. And we align our incentives so that we compensate fairly for those things that are evidence-based, and not so much for those things that are not.
Mm-hmm. Scott, I'd love to hear your perspectives on this too, as a provider.
Yeah, I think, well, first of all, as to Andy's point, I get a call probably every week from someone that has someone in their life that needs help, and they just know that I'm in this space. So I'm the only person that they feel they can reach out to. And they just have a lack of awareness of what really is available, what they should be looking for. So I do think that people like, Caesar and other leaders on the payer side are really doing a good job of helping develop that standard to educate providers and the public as to the proper course of treatment. I know what Shatterproof, I even know what Axial is doing in that respect. So I think it is, to a great degree, a lot of education. People, I just don't think, understand it. I have people call me all the time, and we have levels of care for a reason. People need different levels of care, but so often when I talk to people, they don't know that there's options even. And sometimes there's a barrier to care because they only believe there's one option, and that prevents them from getting treatment. And when I can give them options and talk to them about, no, there are different ways to obtain treatment. There's different levels of care, and maybe you need to be in a different level of care that's more accessible and affordable for you. It really makes a difference. But I'm always shocked at how, across all the people that I talk to, how little they really know about what they need to even be looking for to get treatment. So I think education is a big part of that. And I know, everyone on this phone call is trying to help get that word out there.
Yeah, and I think we've seen that in our own experiences and the work that we're implementing through Shatterproof and the Atlas platform as well, where you'll have people who are ready to begin the search for treatment and they don't even know where to start or what to look for, which led to some of the work we did with the addiction treatment needs assessment, which we created with the American Society of Addiction Medicine and Open Beds to place on the site, so that if you're coming and you're not in that space where even where to start. Scott, you mentioned level of care. I think that's a great flag. People might not even understand that there's different levels of care when they're beginning the search for treatment. So having an understanding of that is critical and allows people to be empowered in the search for care, so that they're able to find both appropriate and high quality treatment. And Andy, I want to pass it along to you for any additional thoughts you have on this topic as well.
Yeah, I would totally agree with my fellow panelists. And I think, my experience would say that there's a couple of steel threads around, I think what we could think of as sort of consumer lack of awareness around options and treatment. I think on one hand, you sort of have this bucket of individuals that perceive treatment as kind of rehab, right? So it's a residential level of care. I've got to travel somewhere to go to treatment. I've got to stay there for 28 days. And I think there's a widespread perception that is kind of the direction that you go when you're seeking help from a substance use disorder. I think on the other hand, we have folks that are probably reticent to talk about or acknowledge their substance use disorder due to stigma, due to other concerns and issues, that will seek care probably more through the mental health side of the system, where they're interested in, hey, I'll talk to a therapist or I'll meet with somebody every week, but this idea of treatment is not for me. And I think that's one of the reasons why we actually don't treat the majority of folks that have substance use disorders. And I think Scott covered it well, that what people don't realize is how many options there are in between those two things, right? And we can find an option for individuals based on their circumstances and what's going to work for them.
Shannon, if I could add, if you look at a medical model, someone comes into my office and they have an elevated blood sugar, I'm going to guide them to a specialist. If they come in and they have a positive test for cancer, I'm going to guide them to a specialist. Many people who are in the throes of substance use active don't have that guide. Some may come in through a primary care physician, some may come in through a crisis, but stigma really keeps people away. So that's why it's very different from sort of a medical model. And we need to be able to extend in ways that meet people where they live, those guides, whether it's through an internet portal or whether it's through some sort of a peer support access or other.
Yeah, no, I think that's a great flag. And I think we always have to think about the ways in which stigma impacts engagement in care, because it's just so entrenched and so such an important thing for the field to tackle, along with engagement in care. And I wanted to acknowledge another huge impact to the addiction treatment space, and that's obviously the ways in which COVID-19 has change the ways in which addiction treatment is delivered to patients. You know, we're seeing an increase in the use of telehealth and telemedicine practices across treatment providers in this country in an effort to be able to continue to provide care to their patients, as well as maintain the appropriate safety protocols while the pandemic continues. And it's continuing far longer than any of us could have imagined, but it's really impacted the addiction treatment landscape in very interesting ways that will likely have some long-term impacts. So I think, Scott, we'll start with you and your thoughts on that. And then I'm sure other panelists have a lot of thoughts. We could talk about this at length. We could have a whole panel on it, I'm sure.
Yeah, I mean, I would first say that you're exactly right. I mean, the use of telemedicine, you know, we would not have made it through the pandemic but for telemedicine. So I am extremely grateful for the changes that were made in the laws, that for the payers that stepped up to cover in places where they had not covered before. And it's been invaluable for us. We've always used telemedicine since we founded this company. Rarely have we used it to the home, but in our offices, we've used it since day one. So to be able to get to somebody in their house without forcing them to come in during COVID was something that we couldn't have done without. I would say, though, that, you know, long term, I see telemedicine playing an extremely important role, especially for ongoing kind of weekly therapy and, you know, check-ins and crisis management, if you will, and even some, I think, on the intake side. But I will say that in my opinion, it can never replace the face-to-face. You know, one of the things that's really damaging from someone struggling with the disease of addiction is isolation. And I can tell you that all of our offices now are thankfully open. And, you know, we have the option of patients still using telemedicine, but well over 90% of our patients come in for care. And I think they do that because they also appreciate that interaction, especially at a time where everybody is still so isolated from just normal daily routine. So grateful for telemedicine. I think it's going to be a big part of the future, but not a complete replacement for in-person care.
Mm-hmm. And you'd love to hear your thoughts as well on telemedicine in this space, as well as we see a growth in it within the provider landscape.
Yeah, I agree with Scott that I think there's always going to be a place for in-person care, and I don't see a world in which we get away from that. I think there's magic to being in person. I will say at Axial, we launched our recovery program in May of this year in Tennessee, and it was interesting timing. We really had a vision for an in-person service where we could work with patients and health plan members within their own community, and have shifted in part to a remote model of engagement, which I think, to Scott's point, has created probably more accessibility for folks. There's an ease of use element to being able to engage on the phone. But, one of the issues that I think, we have to sort of talk about with telemedicine is, the social determinants of health. I mean, there's a high percentage of folks within a Medicaid environment that don't have a reliable phone number. So, it can be extremely hard to adopt those at scale when you're trying to overcome those types of issues around the population.
Mm-hmm. And Dr. DeLeo, having talked about patient context, I'd love to hear your thoughts on this telemedicine, telehealth piece as well.
Well, I think we've accomplished in 4 months what it took us 20 years to get prior. It's really amazing. With the advent of COVID, people were scrambling within the first week to try to accommodate, because we knew that isolation is poison and disrupted care could be lethal. And it was fascinating what we saw. We, prior to the pandemic, we had a very small number of vendored telemedicine encounters across all all specialties, so just not behavioral health or addiction medicine, but across all specialties. But with the advent of COVID, our own provider system and our network providers eclipsed any of the vendors. The vendors may have doubled, but our own providers increased by 4,000%. Currently in our network, we're looking at about 65% of our behavioral health and addiction medicine treatment encounters are now being delivered through primarily televideo. In the Allegheny Health System, within about 3 months of the onset of COVID, we were able to pivot and have 90% of our addiction medicine visits being done via tele, and actually increased the volume by 15%. And so at the end of 2020, we were looking at about 70 to 80% tele rate and an increase in volume by 30%. For some practices across our states, this also had a devastating effect because they weren't able to keep up with it. And we've all read and we've seen of facilities or practices that folded. So I think there was a little bit of a shaking out, unfortunately. But my understanding is a lot of those practitioners then went to work for larger entities that were able to provide that care. Interesting thing that we've learned, we've been able to compare pure telecompanies with the brick and mortar, particularly from our own system. You would think, and there's a lot of venture capital currently going into pure teleplays, but what we've learned is that the uptake, while it's very niche, is not as great as a hybrid model such as Scott's. People want to be seen, they want to develop that trust, they want to make that connection, and then they can transition to a telemodel, which provides a tremendous amount of convenience. Just think of, the travel logistics and, just the time that it saves. Think about the parent who has kids in tow and would have to find childcare and could miss appointments, whereas they can just dial in. And Scott can probably tell lots of stories about that, but it does solve a lot of different problems. And as Andy points out, also creates a lot of different problems because of our lack of uniform access to high-speed internet in this country.
Mm-hmm. Yeah, and I think, first of all, fascinating data. Thanks for sharing that. And I think it's similar to what Scott and you and Andy have mentioned, where addiction treatment is personalized and there will never be this one-size-fits-all approach. So it won't be just telehealth. It won't be, now we have the option for hybrid models, which I think is important, but there's also a place and importance for in-person care. So it's really finding out what best suits the need of the patient that's coming to you and seeking addiction treatment. I think that's a really valuable point as we think about the landscape moving forward. I did also, sorry, were you going to say something?
I'm just going to jump in because one of the thoughts that came to me was also, I think tele is a lever around driving additional conversion to treatment within the population. If we think about the cohort of folks that are receiving treatment right now, it is a relatively low percentage of folks that have substance use disorder. And so again, when we create options for folks, because while there are many folks in that cohort that want to receive in-person care, there are many folks that never go to treatment because they don't want in-person care. And so I think tele creates, again, a lever, another entry point to drive additional conversion to treatment within the population of folks that have SUD, which is something that all of us can rally around. All of us can rally around making treatment more accessible, more affordable, and more available for more people.
Yeah.
And I would also point out, what is tele? Is it telephonic? Is it video? Is it text? Is it digital? I think there's a lot of overlap with digital and digital supportive tools. I think it's hard to be purely digital, but they can be complementary. So I think our concept of what is the right recipe, I think you pointed to, there has to be some curation and cultivation of what's right for each patient.
Mhm.
I'll say also, Shannon, if I can, one of the things that we see, obviously, when you have a lot of MAT, medication assisted treatment in the opioid space, especially, and rightfully so. But that treatment protocol generally follows a monthly protocol, and especially in times like we're dealing with as a country now, monthly, a lot happens in 30 days. So one of the ways that we've been able to use that hybrid model is just the check-in. Even before we knew we could get paid for telephonic visits, we were checking in with people, just to make sure they're okay. So I think that's where telemedicine has helped us so much, is to have some additional connectivity to our patients when they really were in almost crisis situations a lot of times, because of the world. It's really been difficult the last year for everybody, especially for someone struggling with addiction.
Mm-hmm. So important. Thanks, Scott. And I think we'd be remiss if we didn't also talk about some of the things that have come up in talking about telehealth, which is, some of the disparities we see with access to technology. Scott, you mentioned, I'm sorry, Andy, you mentioned, Medicaid populations and phones with the advent of telehealth in this space. And I think, we have instances where we're seeing, caseworkers, recovery support services to try and address some of the challenges that patient populations face as they're attempting to or engaged in care. So I'd love your thoughts and perspectives, maybe starting with you, Scott, on what we do to create a whole patient or patient-centered approach so that people who do have competing contexts and needs outside of the treatment program itself, whether it's having housing insecurity, whether it's limited access to technology. I know we have these problems with rural environments where people have challenges accessing care, and that's something that we're trying to be thoughtful of and approach as we try and make high quality addiction treatment available to all people. But then it's also thinking about the person specifically, whether they have past experiences, trauma, or otherwise that impact their ability to engage in care. So I'd love to start with your thoughts and how patient context and needs really impact the way we approach treatment and what services we're able to provide to support them.
Well, there's a lot in that, Shannon.
Yeah. Oh, yeah.
So, obviously most of our locations are in rural areas. So we're, very familiar with the rural population, with the difficulties, as Andy suggested, with just technology. We years ago tried to implement an app-based program to help us have more interaction with our patients, and found that most of our patients in the office that we started with didn't have a phone or a capability to even download an app, and learn very quickly of those types of limitations. More than 40% of our patients are unemployed. So, you have, a lot of different things going on. I can say that for us, we work really hard to know our patients, to know our communities, to try to be creative in finding ways to communicate and be in contact with those. It's a relationship building exercise, really, in a lot of these situations, to be able to connect to the patient. And then once you can connect to the patient, there's a lot that goes into treating the complicated disease of addiction. And it's not just medication and always counseling. It's a whole set of social determinants of health that impact someone getting care, and I think also someone staying in care, both of those things. So it's a very difficult thing. Trauma is a big part of that. I know, other panelists will have a lot to say on that, but it's definitely something that we work on. In every one of our patients, we utilize the ACE study, the adverse childhood experiences, and it's been shown that there's obviously a great connection between childhood trauma and addiction and even attempted suicide. I think the studies show that you're 1,200% more likely to attempt suicide if you had a 4 or higher on the ACE study. So I think it's important to understand the relationship between how you were brought up, your life circumstances, and how that impacts your treatment. And it also just, I think, reiterates how important it is to have good quality behavioral care alongside medication and case management and all the other things that are required for holistic care.
Yeah, and I'll jump and ask for Dr. DeLeo to comment on this from the member perspective, and then thinking about how to get more holistic care and support services to members as they search for addiction treatment and engage in addiction treatment services.
Well, so much of SUD doesn't walk alone. You have ACEs, you have social problems, you have housing insecurity, you have domestic violence, and so, you know, the idea that you just can treat addiction alone is really a fallacy, right, Scott? You're smiling at that. It takes a whole holistic team. So that's what we want to make sure that people get to, a whole holistic team. You had mentioned before about sort of, you touched on some of the literacy aspects. I mean, we have, healthcare literacy, we have digital literacy, we have the older population that just does not really relate to digital formats, and you have language too. So maybe digital can help with that, but social determinants are big. Digital and video and tele all have the opportunity to have the practitioner actually peer into where the patient lives, which is a perk, or it's a violation of privacy. It can be interpreted a number of different ways. And there's a lot of trust that needs to be generated, particularly if someone is living in an environment in which there are less than legal things going on perhaps in the background. But I think we're committed to making sure that people get to holistic practices, and that they're holistically evaluated, and that means social determinants. And with we use Aunt Bertha as one resource across our different health plans, and we know that Axial and their peer support program, we've made Aunt Bertha available, and they communicate and coordinate with our case management, and it's a great tool, and it's a nice collaboration.
Yeah, and Andy, that's a good segue to you and your thoughts on this space with axialHealthcare.
Yeah. So I heard kind of two parts of the question. I'm extremely passionate about trauma-informed care, but I'll parking lot that and focus on what our obsession is at Axial, which is helping individuals and families address and overcome social determinants of health, and providing the wrapper services necessary that allow folks to stay adherent or engaged in care longitudinally. This is an area of tremendous white space in the ecosystem. I think that it's an area that's extremely ripe for innovation. And I think it's, having been a provider, it's an area that's also very, very hard to solve at the provider level. Because it's challenging to, especially if you're in an outpatient setting, and Scott and I have talked a lot about this. He invests a ton of resources in supporting their patients beyond the point of service, beyond the care that they're providing. And that can be extremely costly, extremely time intensive. And a lot of the work that we do at Axial, creates partnerships with providers to support them in that area, because one of the things that we believe is, if a patient doesn't have stability around housing, stability around their transportation, some stability and support around their family system, it's extremely hard for them to stay engaged in care across time and space. And so this is an area that we're really passionate about, and we're working really around the clock to try to innovate around and solve.
Yeah, thanks for that. And I will say, within our work at Shatterproof as well, and thinking about social determinants of health, we're thinking about the ways in which, they're addressed through treatment, but also the way we measure people are assessing by social determinants of health, and the things that facilities have available, like recovery support services. So I think in this discussion, it's very clear that it's top of mind in the field right now, because as Dr. DeLeo said, you're not just treating substance use disorder, you have to treat the whole patient. And I love that because it's just so true. And I would love to stay in this discussion forever, but I think we need to move on to measurement, which is another important part of Atlas. Love measurement and thinking through how we use measurement to standardize the ways in which addiction treatment is delivered, making sure that people have access to high quality care. We want to start first with you, Scott, and acknowledging, we started saying there's a lack of unified standards in this industry, and in general, organizations or in agencies in these different groups who are invested in understanding whether high quality care is being provided, they're using different measures and tools, and there's some burden on providers to provide that information. So would love to hear your thoughts and perspectives on that, and what you as a provider have to contribute and measure to show the quality of your services.
Well, I think I wouldn't classify it as a burden because I think it's so necessary. I also wouldn't categorize it as easy. We employ a full-time epidemiologist, Katie Webb, and she's tremendous. And we work very, very hard to collect data and understand our patients and the patients we're trying to treat. So we kind of break it down into three areas. We look at the demographics to just try to get better insight into where our patients are coming from, what they're having to deal with, their social situations, all those, very important things that help go into treating someone for addiction or mental health. And then we look at it also in cost savings. How can we track measurements that we believe adds value to the system and saves money overall from a holistic healthcare standpoint. So we track things like ED visits. We track things, like relapses. We look at the impact counseling has on our patients. Like we find that 89% of our patients receive in-house counseling, and someone that receives counseling in our treatment is over 3 times, it stays in care more than 3 times longer. So the average length of care is about 18 months if you receive counseling, and it's about 5.5 if you don't. So we track things like that so we can better understand how to provide that care. And then I'd say lastly, we look at it in quality. How can we get better? How can we be better at treating polysubstance? How can we be more effective in tapering benzodiazepines? How can we look at that patient population and what we're doing and how we're treating them and the social determinants of health? Is all that working, co-occurring? Obviously a massive issue when you're dealing with addiction. So we work really hard to capture this data in a manner that makes it easy and digestible and reportable and verifiable, but it's not easy. So it's a full-time job, and I think just have to continue to get better. And then we work with folks like Axial and obviously Caesar and other leaders to help, I think, identify what's important to the industry as a whole and to delivering the very best care and continue to work to get there. Yeah,
and I will say obviously that I love to hear how important you think measurement is, since we're very invested in measurement as well. But I want to open it up and using a data-driven approach, like that's so wonderful. I want to open it up to Andy and Dr. DeLeo to see if they have any additional thoughts on this.
Couple.
Yeah.
Scott, I love the way that you put the quality on that. Not only do you measure, but you analyze and improve. And I think that's the way that that we move our profession, our industry, or whatever you want to call it, forward. You go back to the basics of structure, process, and outcome, and we're in the process of developing that sort of a lens on our network. And then finding out where there are opportunities to improve. We do that. We're looking to do that on an individual basis. We already do that in the medical end. We do that with our medical practitioners and have different levels of value-based reimbursement. We do that with our hospitals. We've started to do that with our ASAM 3 and 4 facilities, and now we need to do it with our behavioral health practitioners, which includes. I'm going to include in that primary care physicians who are also behavioral health practitioners. And and substance use disorder. And then in the aggregate, we look at how we're doing as a network. And, for example, at Highmark, over the past 3 years, we track overdoses. We've been able to cut those in half. We track prescribing of opioids, and we work closely with Axial and their data scientists to look at that, and we've decreased that number by 27%. But and we've also increased the percentage of individuals who are receiving MAT treatment, which is a surrogate of treatment. We want to be able to slice that and look at quality of treatment as well. We even convert this to lives saved. So we like to say that, based on the numbers that we've moved over the past 3 years, we can comfortably say that we've saved 429 lives. So that puts a human spin on it. So.
And I think that human spin is so important. Andy, anything that you'd like to add to this important conversation about measurement?
Yeah, I mean, I think a lot of great things have been brought up. One of the things I think about with measurement is when we think about treatment quality, what's the definition of treatment? There's multiple levels of care within the treatment ecosystem that have different purposes and use cases within a member or patient journey. So I think we have to create outcome measurement that flexes to the purpose of the service or the level of care. The other thing is there's a lot of different, I think, versions of outcomes, and I'm excited about the work that's being done at Shatterproof. When I think about outcomes, I think about three things. I think about clinical outcomes, I think about operational outcomes, and I think about utilization outcomes. And those are really kind of the three things that I think cover with relatively comprehensively the picture of potential outcomes. And we're hard at work, and I think one of the goals that we have is to try to find the balance between those three things within patient outcomes that we're supporting.
Yeah, and Andy, I'll press on this a little bit with you and say that we discussed how in general there can be a focus on abstinence-based outcomes, and I'd like to give you the space to dig into this a little further, because you mentioned patient outcomes. What do you think is important to prioritize in this space and to really move the work forward in a productive way when we're thinking about and using patient outcomes as the way to assess treatment quality?
Yeah, I mean, if you think about the context that I just brought forth, abstinence, I'm not a clinician, but abstinence is maybe a clinical outcome. So it's maybe one part of a larger picture of the total outcomes that we could be working towards. And yet it's really this sort of sole thing that we talk about, or is commonly referred to. And I think the treatment ecosystem is, we've got to get folks sober. We've got to get folks abstinent. The reality, I think, is that there's much more to optimal outcomes than just that one thing, and we have to think about it more broadly, and we have to think about it again with an approach that factors for much more things than just whether someone is using or not. So that's definitely my perspective on it.
Yeah, and I'll open it up to Scott and Dr. DeLeo if there are any additional comments on that, especially thinking about those patient outcomes and what are the most critical to capture. I know both of you are very data focused, so I think you have some important perspectives here.
I'll tee it up for Scott, but we're talking about, instead of binary variables, these are continuous variables. The diabetic that comes in with a sugar of 200, you're not going to discharge from your practice because they were a non-compliant diabetic. And so too, if you have somebody comes in and they may have consumed some alcohol, it's a continuum. And what is cure? What is long-term remission? It may be different for different people. Certainly, some conditions where you're injecting drugs it's not good, and abstinence, at least from injection, is the goal. But I'll hand it over to Scott because I'm sure he has great insight into what this is, the change of the paradigm.
Well, I think, thank you, Caesar. I think for us, we are always trying to just get better. And I look at treatment, in terms of, I've said this before, when we think about it, the number one thing is we're trying to keep people alive, which is why I love Caesar personalizing it. And one of the best ways to keep people alive is to keep them engaged in treatment. So many people fall out early and leave and come back. So a lot of what we try to track from an outcomes measurement standpoint is what's impacting people that are leaving our care or they're not progressing in our care. And that is all types of things. A lot of it's social. One of the reasons that it's very difficult to track and verify outcomes is because so much of what impacts that occurs outside of our care. So you have to really have the data points, the connection points to the patient to capture this data and analyze this data. But I did use like the benzodiazepines as just an example, but there's other things that we measure and look at because we see it continuously as a problem. We see so many people that come in that are an opioid patient. They're also taking some type of benzodiazepine, and we start the process of trying to transition them away from that. And I can just tell you, the data shows we lose that patient all the time. So we're constantly trying to figure out, how do we keep that patient engaged in treatment? What is it that we're doing that's working from a counseling standpoint, from a case management standpoint, and what's not? So for us, that's the ultimate goal, is identifying those problem areas, tracking solutions through outcomes. And again, it's not perfect, but you just got to keep trying, and you got to know your patient. It's a relationship. If you don't have a relationship with your patient, if it's transactional, you're gonna have a hard time understanding what they're going through from a holistic standpoint and what's necessary to keep them progressing through care.
Yeah.
As we develop metrics, we also have to keep that in mind, that there is no absolute. And if we incentivize something over the continued engagement of the patient, then we're missing the bigger picture.
Mm-hmm. So we have to move on again. So sorry, but I wanted to leave time for us to talk about how we expand access and engagement in high quality addiction treatment, since I think we're all doing interesting and important work in this space. I'll give each of you a moment to talk through and describe how your organization and through your work you're trying to really help to facilitate engagement in high quality care. I think we've talked about with Shatterproof, we have Atlas or treatmentatlas.org, which we have available now in 6 states, and it's a quality measurement system for addiction treatment facilities. So people are able to go on our site, type in their location, use filters and other to customize their search to factors that are important to them, and search for and compare and find high quality addiction treatment. We also have the assessment to start their journey, Scott, as you mentioned, so that they have the information they need. But I think in addition to that consumer facing element, we also have portals, and we're engaging with providers and state agencies and the health insurers to understand how our data might support them in their work, how they can see the information that we've collected through Atlas and use it to drive innovations in the space. Scott, as you mentioned, facility data-driven quality improvement work is critical, and it's a way to improve the services that patients are receiving through the facility. So I loved that. But also giving information to states so that they can optimize their resources and think about where some of the gaps in care might be. And with health insurers, giving them the information to look at how providers within their networks are performing, so that we're able to achieve something that's really needed in the space, a systems level approach. And I know Dr. DeLeo, Highmark is really taking lead on thinking through how to facilitate access to high quality care. So I'll start with you and give you a moment to talk through some of your work. I know we're running short on time, and I want to leave a couple minutes to Q&A, but I would love to hear a brief overview of your work at Highmark and how it's supporting this.
Well, I think we touched a little bit upon care management, peer support, Atlas. We have joined forces with Google and Google Cloud and the Google Dynamic Platform, and how we can bring together disparate systems to be able to synthesize information for members and create a remarkable user experience. And I know that we're talking about addiction here today, but I just want to point out that we really focus on a continuum of prevention, mitigation, and then for people who slip into the third prong of addiction, harm reduction, and then sort of social reintegration. And we're focusing on the addiction treatment, but I want to acknowledge all of those other parts. I want to acknowledge the fact that it's important for us to increase access to care, and I think that's with the elimination of the X waiver. France did that back in 1995, and they were able to increase their number of people in treatment tenfold. So I think that's a huge opportunity in the United States, where only 6% are waivered. Only half of those use their waiver. I'll give my time to my fellow panelists, the remainder of my time.
Very generous. Andy, we'll give you a moment to also talk about axialHealthcare and how they're working in this space, and with Scott as well, in acknowledgement of all the impressive work Highmark is doing. Dr. DeLeo, thank you so much.
Yeah, sure. Thanks, Shannon. Probably won't overplug here, but I think I've highlighted, we're extremely passionate about serving individuals and families that are seeking treatment, and filling gaps in care, and also creating innovation around the white space that exists, because I think there's a lot of it. I was thinking a little bit earlier about our conversation about outcomes, and I think data plays a massively critical role in that. And one of the things that we do at Axial is, we're a data and analytics driven company. So we use data to target and prioritize our outreach and our engagement with patients. We use data to translate things between health plans and providers. But at the end of the day, also, while that really matters and it's critically important, the patient that's going through the treatment journey, most of them, I promise you, don't care about that their utilization is inefficient. And so we have to figure out a way to translate this down to the member and patient level. And that's one of the things that we do at Axial with our interventions and with the support that we're providing to people within communities.
Thanks. And Scott, we'd be remiss if we didn't talk about your involvement in high quality and addiction. So giving you some moments here to talk about your work and thinking through how we expand high quality addiction treatment.
Well, I think it takes a village. I think we all have to work together to expand quality care, all the things we've talked about, creating the standard, education, those types of things. We have great partnerships with our payers. We work very closely with them, and I'm so grateful for the recognition that you're seeing today that you didn't see 5 or 6 years ago, in terms of the value of evidence-based care, how that ultimately helps people and reduces the overall cost of healthcare. And I think it's a very complicated disease, requires medical and behavioral and social, all the things we've talked about. So it can be very expensive to treat. And I know that for us personally, we've taken the stance that above all, we're going to try to help people, and we're going to worry about the financing side of it later. But it's very difficult disease to treat. And I think just recognition of that and continued reimbursement programs and support from the payer side, I think really does go a long way to enhancing and increasing the quality of care we see across the spectrum.
Great. And I will say that now we're going to give a couple minutes to our Q&A. We've had some interesting questions coming in from our participants. Thank you, participants, for sending in your questions and for joining us in this conversation. I will note that any questions we don't get to within this panel, Axial Healthcare will be addressing in any of the follow-up materials. So don't worry, your questions will be answered. That we just might not get to them now because this has been such a strong, important conversation. So one of the first questions that we have essentially focuses on how, I think, points you've made, Dr. DeLeo, and also Scott and Andy, about how there were existing providers in this space, and there may be some reluctance towards what we see as new evidence-based treatments for addiction treatment. So this is probably a gigantic question for you all, but how do we convince entities that have been in this space for decades that things like medications for addiction treatment are evidence-based, valid, and life-saving practices? And I know, again, gigantic question, but would love your thoughts.
Education and alignment of incentives. Simple answer.
Simple but great answer. Andy, Scott, anything you want to add?
Go ahead, Andy. I'll let you take that one.
I think, so AA does not have an official stance on medication as an entity. It's important to know that. There's variance in what you'll find within that community. And I think it's about finding the right pockets within the community that support patients that are going through MAT.
Great, thanks, Andy. And then we'll do one more question before we wrap up. And again, thank you everyone who came and listened to this discussion today. I hope you've gotten as much from it as I have. And the panelists have been absolutely exceptional in responding to and thinking through addiction treatment quality and what it looks like and how we might approach expanding it in the future. So we have one question that says, do current assessments like ASM clarify whether concern is physiological, sociological, psychological, behavioral, etc.? If not, why would MAT be the gold standard versus specific treatments for each of the pathologies mentioned?
Oh. Caesar, you want to?
So, what are the causes? Genetic, environmental, there are many different causes, and I think you have to look at each patient individually and assess what their needs are. And oftentimes that's a coordination of a lot of different modalities. Medication alone is not high quality care. It's medication in conjunction with appropriate counseling, bolstered by other modalities that are going to really be dictated based on what the patient's other physical and medical comorbids are. I'll hand it over to Scott.
Yeah, I would agree with that. I think that for us, I look at medication as really harm reduction. When I talk to people that don't understand medication and where it coincides with behavioral therapies, medication allows us to help keep people alive, and it allows us to work on the other things, the behavioral, the social, all the other aspects that we know go into helping that patient get better. So it's just one thing, and we're seeing obviously a lot of other things now, whether it be alcohol use disorder or methamphetamines or other stimulants, and while we've got great medications for opioids and even for alcohol use disorder, not as impactful for some of the other addictions. So you really have to look at, like any other medicine, what's the disease? What are they struggling with? How do we best treat them? Does medication, is it going to be impactful to their scenario? But we know across all of that, and we try to think of ourselves as a behavioral medicine company, we know that it's always going to involve, some type of behavioral counseling, and probably for sure a social aspect as well. So I think it's just education and, continuing to push forward to a standard of care that we all accept and adopt.
Thank you, and that's great. And I'll have to say with that, we have arrived at the end of this panel presentation. So I'll first say thank you, Scott, Andy, Dr. DeLeo. You have been fantastic panelists. This has been such a strong and important discussion for this space, and we appreciate your perspectives and the thought that you've brought to this hour-long discussion. Again, for our participants, if your questions weren't answered, these will be addressed in the follow-up materials. And we'll say, check your email in the coming days, because we'll be providing a recording of today's webinar. And thanks again for choosing to spend time with us today and listening to this conversation. And hopefully it elicits even more conversations about how we work to expand access to high quality addiction treatment. So thank you all.